Hello, this is Dr. Bhomik. Welcome to my pediatric endocrine metabolic lecture series. I hope you are all doing well. And today I'm going to talk to you about hypercalcemia in pediatrics. This is the continuation of the lecture that I started as pediatric endocrine emergency. In that series, my first lecture was on neonatal hypoglycemia or hypoglycemia in children, and that was followed by hypocalcemia in children, adolescent and newborn. And this is the last lecture on that series is hypercalcemia in pediatrics. Now again, I'm going to divide it in neonatal period and the children. So the list that I have put here is clearly incomplete because it's not possible to put everything here, but the one that I have put here is, I believe it should be more than enough for you to know. And truly that this is probably will be more helpful in the pediatric or endocrinology board examination. And this situation will be mostly taken care by neonatologist and endocrinologist. But for the completion of the discussion, I'm going through not all the list, even among them is not all the list, but the one that usually is more common. Among the rarest, but this is still more common. So we will be talking about idiopathic infantile hypercalcemia, excessive vitamin D ingestion by mothers, and this one I'm going to tell you because there will be no separate discussion on that, because if the mother during pregnancy taking too much vitamin D, her calcium level will go up and that calcium will go to the babies as well. So baby will be living in a medium of somewhat hypercalcemia. So when this baby will be born, it will take few days for the calcium to normalize. Then we'll be talking about the maternal hypercalcemia. Now in this situation, if the mother has, say for example, a parathyroid hyperplasia or adenoma, the calcium level in the mother is clearly going to be high. And as a result of that, the baby is going to be exposed to a lot more calcium in utero than he or she would have been. So what it does, it suppresses the fetal PTH level. And PTH is active from the 20th week or so. And so it suppressed it. So when the baby is born, again very similar like vitamin D ingestion, the hypercalcemia is going to persist for a while and then it will abate it. Now, the maternal hypoparathyroidism, on the other side of the coin, is usually mother is living in the medium of low calcium. So when this calcium is low, the baby is also going to get less calcium. But as I said, the parathyroid axis is active from 20 weeks onward. It is more important the parathyroid related protein, which is more important for the deposition of minerals and the calcium in the bone. So as a result of that, baby will activate the system. So parathyroid related protein and the PTH level will go up in babies just to normalize the calcium. So it will not only normalize, but when the baby will be born, it might actually born with hypercalcemia, which is rare, but for the completion of the discussion, I just have to mention that. Then we will be talking subcutaneous fat necrosis and familial hypocalcemic hypocalcemia. familiar hypocalcemic hypercalcemia in a different slide. Okay, so the entity that I'm going to discuss with you now, idiopathic infantile hypercalcemia. Well, there is no identifiable cause, but it is a genetic condition. There are two types has been described, type 1 and type 2. And it is, type 1 is linked with the different gene CYP24A1 or cytochrome P24A1, and it's located on the chromosome number 20. And what it does, it's somehow supposed to clear the metabolic parts, the metabolic product of vitamin D, 25 hydroxy vitamin D, 125 hydroxy vitamin D. But defective in this gene appears to keep those levels up for longer period of time, and as a result of that, it's just like a little bit of more vitamin D for the babies, and that increases the calcium level. And on the other hand, SLC34A1, who is the solute carrier 34A1, and it is on chromosome number 5, it does interfere with the metabolism of sodium-dependent phosphate. And this is for the sake of completion of the discussion, but I don't think anybody need to will ask you that question or to remember it, but for the completion of the discussion, I'm going to just go through this. And so as a result of that, the body might feel like a little bit more exposure to the hypophosphatemia and also a little bit of hypervitaminous. And so, and this is again is not clear cut and written in the stone. These are supposition. Now, since this condition might persist for lifelong, so as usually you will see, the patient will present and will continue to have polyuria, feeding problem, failure to thrive, psychosocial psychomotor retardation, and this will continue as the age progresses. As a result of hypercalcemia, there will be hypercalciuria, so these children are more prone to develop nephrocalcinosis and the kidney stone, and later on osteoporosis. Now I'm going to talk to you about the neonatal hyperparathyroidism. Rare, very rare. However, it could be very devastating. And most of the time that when this occurs, the patient has significant hypercalcemia and PTH level is high, and so as the PTH related protein. And this is most of the time is caused by the hyperplasia of parathyroid glands. So multiparathyroid gland hyperplasia. And severe hypercalcemia present within the first 6 months of the life, but it could be even earlier. And this is done by the homozygous mutation of calcium sensitive receptor gene, which is located is chromosome number 3, key long arm 13th. Now this is homozygous mutation, but if it is heterozygous, only single gene mutation, then it will be familiar hypocalcemic hypercalcemia. So one gene involvement, hypocalcemic hypercalcemia. Let's think this way. If the mother has one gene mutation or hypocalcemic hypercalcemia, familial, and the father also have the same condition, and the baby get the double dose, that means both involved gene has come, one from mother, one from mother side and the father side, then it is the homozygous situation, and that is very dangerous. In this case, very intensive medical therapy will be necessary, and in fact, the parathyroidectomy will be the last resort. Now I'm going to talk to you about something called subcutaneous fat necrosis. As you will be seeing that these slides, they are kind of busy, that too many things in a slide. The reason why I have done that, because these are not common condition. If you just read this statement or the slide itself, you will be able to answer all the questions that hopefully or if you get in your exam. So that's what I made this slide. This is not ideal. Ideally, there is one statement per slide, but I realizing that, but it will be more helpful the people, those who will be taking exam or those who want to learn more, and so this just a slide will be helpful. So it's usually a full-term baby, and they present with erythematous nodules, plaques over the trunk, buttock, or the thigh, and they appear in first week of life, but it can be, first time it can be seen in 1 or 2 months of age. So why this thing happen is not exactly known, but we have a supposition or postulated etiology. What explain the situation like this? But it does really make sense though. These are the baby clearly exposed to significant cold exposure, hypoxia, stress-induced injury. And when this thing happen, the blood supply from the skin and the immature fat cells are shifted to the vital organ. So this is a protective mechanism that we see in all conditions. In shock in adult, the blood supply is preferentially goes to the most vital organs in the body. So this is same thing is postulated. So the shifting of the blood supply occurs from the ones supposed to be not very important, like a skin and immature fat cell. And hypercalcemia begins at the age of 1 to 2 months, but I have seen one patient started at 1 week. Now, although majority of them, as I said, that they will get better automatically over the period of time, but about 1/3 to 30 to 40% may have significant hypercalcemia, and which might give you problem. But usually, as I said, it is self-limited process and it will get better over the period of time. But hypercalcemia will be treated with fluid and furosemide as per protocol in your nursery in ICU. Now I have got some good diagram to show you, and here is the right here and the here and here, and this is the little picture right there, there and there. Now these are the newborn period or infant less than 1 year of age, but here I am going to talk mostly about childhood and adolescent hypercalcemia. Obviously, we are going to discuss about hyperparathyroidism in pediatrics. Then we are going to discuss about a condition which seems to be a kind of favorite board examination, Williams syndrome. Then we're going to expand a little bit on familial benign hypocalciuric hypercalcemia. Then food fatism or vitamin D ingestion, too much vitamin D ingestion. Chronic granulomatous disease, which is rare in pediatric age group, but I will mention for the sake of completion. hypercalcemia of malignancy, and the immobilization if the child has got bad fracture and need to be immobilized for a longer period of time, just like adult, they will have same kind of problem. So let's move to the next slide. Primary hypoparathyroidism is very rare in children, extremely rare in children, and even so in prepubertal children. So when it occurs, it's usually caused by a single benign parathyroid adenoma, which is about more than 80% of the cases. Indeed, it is rare in children, and the incidence seems to be 2 to 5 cases per 100,000. 2 to 5 cases per 100,000, as opposed the adult is rather common, is 1 to 7 per 1,000. So that goes to show that how rare it is in children. And the other thing else in some series has been noted that adult series is the female preponderance is about 3 to 1. On the other hand, in children, it seems to be male domination, 3 to 2. And it is extremely uncommon in prepubertal age group. We published a report of 9 years old who has single benign parathyroid adenoma presented with intermittent hematuria after exercise, and that kid had parathyroid adenoma. So even it is extremely uncommon, but it does exist. Now, sign symptoms of hyperparathyroidism is not going to be not much difference from the adult. The sign symptom will include the bone pain, kidney stone, increased fracture, and asymptomatic hematuria, abdominal pain, and pancreatitis, etc. In many cases, nowadays we order lab tests which include the chemistry panel, and that will have calcium, phosphate with serum electrolyte. And many of the time that it can be just detected because of the routine blood test for the chemistry profile, and then you have to investigate and you might find this patient may have hyperparathyroidism. The lab test is just very same like adult. They will have elevated calcium, low phosphate, increased parathyroid hormone, and hypercalciuria. And the imaging test is again very same like System B scan or technetium 99 or SPECT scan. Very same like adult. Now, one of the things I just want to mention that this sometime the early onset of parathyroid adenoma or hyperparathyroidism may look like familiar hypocalciuric hypercalcemia, because in that condition, as I will discuss later, the PTH level may be mildly elevated. So only way you can differentiate them is the urinary excretion of calcium, which will be universally high in primary hyperparathyroidism. Again, treatment is surgical removal of the affected parathyroid gland, and it is done by the surgeon, and they probably will look at the other parathyroid gland as well. Now this one is a pretty favorite board question. This is called Williams-Burden syndrome, and this is because of at random deletion of chromosome 7q11.23. And these patients are born with a called elfin phase depressed nasal breath, and I have seen quite a few, but I have sometimes a hard time to appreciate those elfin phase. And they have been described for the purpose of your exam in the literature. They are overly sociable, cocktail personality, but mentally challenged, and they are developmentally delayed. But by looking at them, when you talk to them, and they look like they are pretty smart. And hypercalcemia is interesting. Not everybody who is born with hypercalcemia, could be about 40%, but hypercalcemia tend to disappear as they progresses, as they become more uh, mature. So by the time they are like 18 months, 5, 6, 7 years, hypercalcemia is totally gone. So hypercalcemia is mostly seen in the first year of life. And for both questions, there is another thing called cardiac defect, is known as supravalvular aortic stenosis. And they are no treatment is necessary, excepting the aortic stenosis should be followed by the cardiologist. Should avoid extra calcium and extra vitamin D or excessive vitamin D. And it is believed that this condition is sensitive. These children are very sensitive to vitamin D. This condition was first described after Second World War in England, when they routinely started putting vitamin D as a supplement to the pregnant woman. So, and indeed, that if they do not have hypercalcemia, if you give some vitamin D, you can bring about hypercalcemia. And so I have got these two pictures, and this is supposed to be elephant face, light elongated face, depressed nasal breath, and obviously this is not my picture. I have got from the other sources, and these two boys has Williams syndrome. And this is a very nice picture of supravalvular aortic stenosis. Supravalvular right here, aortic stenosis. Now I'm going to talk to you about the familial hypocalciuric hypercalcemia. Actually, this condition is not that rare. And this is also known as benign hypocalciuric hypercalcemia, because this condition is detected usually by routine lab test and they do not have any symptoms. And this is important, and this is because of the heterozygous loss of function or mutation of calcium sensitive receptor gene. And so it is a single gene, and so therefore the findings of hypercalcemia is never that virulent. It will be the range that I will discuss in the next slide or so. And gene location is 3q21. So this is the heterozygous loss of function of mutation of cis-paired gene. It is expressed in parathyroid and kidney. What does that mean is this. So it takes a higher level of calcium for the parathyroid to suppress its secretion. And it lacks high level of calcium, so the kidney also do not dump the calcium the way it should be, because it is also seems to have higher threshold for calcium. So therefore, this is where you will have a hypercalcemia and you might have mildly elevated PTH level, and the best differentiation in this case will be urine excretion of calcium, and the condition is autosomal dominant. So clinical features of familial hypocalcemic hypercalcemia, as I said, it is most asymptomatic hypercalcemia found during the routine blood test. Sometimes the hypercalcemia may go up to the range of hyperparathyroidism if they are significantly dehydrated. The calcium level varies around 10.5 to 11.8 milligram per deciliter, and this is the key. The low urine calcium creatinine ratio. Normally it is more than 0.02, but here it is less than 0.02, and the few that I have seen was 0.01, actually lower than what I have put in my slide. So in this situation, this is a very important diagnostic feature, and finding this one pretty much tell you that this is a hypocalcemic hypercalcemia and most likely familial. So it will be a good idea to check the other children and father or mother, whoever is not been screened, and that way you will be able to identify. Mildly elevated PTH level, as I mentioned, might confuse you with the early onset hypercalcemia, but again, urine test will prove. And as I said, parathyroid and kidney is hypersensitive. So other non-parathyroid hypercalcemia obviously is going to be hypervitaminosis D, and excessive consumption. Sometimes the people feel that too much vitamin D will make their bone more strong, and that is not the case. They will have hypercalcemia, and vitamin D level, 25 hydroxyvitamin D level is going to be high, and PTH level is suppressed. Then it could be chronic granulomatous disease. Unfortunately, this is not very common in pediatric age group, and they are histoplasmosis, leprosy, tuberculosis, and sarcoidosis. Now, the mechanism appears to be T cell macrophage in the nodule. T cell and the macrophage in those sarcoid or tuberculous nodule make 1-alpha hydroxylase enzymes, and which convert 25 hydroxyvitamin D to 125 hydroxyvitamin D active form there in the granules. So that granules has 1-alpha hydroxylase activity. Now, hypercalcemia of malignancy is also rare, but it does occur, and it's just nice to remember that some of the hypercalcemia that is reported is usually with leukemia, lymphoma, neuroblastoma, dysarminoma, and some few others. And it occurs actually less than 1% of the children with cancer, and the etiology appears to be osteolytic or direct invasion of the bone cell by the tumor by metastatic process. The hormone that mostly you chew is the parathyroid related protein, and this is not PTH as much, but it is parathyroid related protein. The other factor may include prostaglandin, interleukin, etc. So I conclude my lecture by thanking you for listening. And so we have discussed hypoglycemia, hypocalcemia, and hypercalcemia. And so next series of the lecture will be different. But before that, I might put some pediatric board related questions before I go to my next lectures, like Cushing syndrome in pediatrics, addiction disease, etc. Thank you very much.